Welcome to this episode. I'm your host, Arshad Khanani, and I'm joined by my good friend and colleague, Dr. Margaret Chang, who's a senior partner at the Retina Consultants of Sacramento in Sacramento, California. Margaret, thanks for being here.
Thanks so much for having me.
So, in this episode, we'll discuss new clinical evidence on dosing regimens, delivery systems, and emerging therapies for the treatment of neovascular AMD. But, Margaret, before we dive into the data and the discussion, we ask our faculty a few questions up front. So, tell us a little bit about how did you end up doing what you do, meaning being a vitreoretinal specialist?
I was originally all set to go into cornea before I started residency because I couldn't see the retina when I was a med student. But during my first year, I assisted Ray Sharda when he performed submacular surgery. And I thought that was the coolest thing. And I thought I really wanted to do that. So that's really how I got started. I made the switch.
Yeah, I mean, I think cornea is also very interesting, and I think many of our mentors play a big role in how we define our career. So tell us a little bit about yourself. What is your favorite hobby?
So, unfortunately, most of my time outside the office is taken up by trying to wrestle with my three kids and being a master schedule for my family. But when I do have time, I love to bake. It really requires a lot of precision and measurements, but I have to try and bribe them with something when I come home. So that's usually what I try to do.
Got it. And I know you have three boys, and they're into fencing. Do you fence also?
No, I like to try and just keep myself on the sidelines. Fencing is a great sport for them. I don't know how they do it. It takes a lot of concentration. My middle kid actually sprained his wrist at summer nationals this last summer, and so it wouldn't be a good sport for me. But he still won. So I'm super proud of all of them.
Yeah, it's really not an easy sport, and I'm glad that they're doing it. But it's yeah, so much precision is needed. Baking, I don't like to bake, but I like to eat all the goodies that my patients and the staff may bake for me. We have some really good bakers in our practice, and every day I show up and there's a cupcake or there's a cookie, and I'm like, there goes my diet. But baking is not easy; also require precision. And what about vacation? What is your favorite vacation spot?
Also hard to choose. Wherever it is, we love to cruise. So we love going by cruise boat because basically it's a relaxing way to go. You don't have to unpack, and there's limitless food options, and it's just an easy way to travel. So we try to do a cruise every single year.
What was your favorite cruise?
We just went to Norway, actually. So even though it rained a lot of the time, the scenery is spectacular, and it was just spectacular. But we just did do a cruise around the Horn of the Cape Horn, and that was great as well. We saw the like huge penguins down there. So many great places to go around the world.
No, I believe it or not, I've never done a cruise, and I'm looking forward to definitely getting on a boat here with my four kids. It is. You're right. I mean, there's so many different options, and it's more relaxing than trying to wait for planes and having the delays and flight cancellations that happen late in slots. So, all right, let's dive into some of the discussion topics today. Of course, we have first generation, anti-VEGF, aflibercept, 2 milligram ranibizumab, and they do well. Of course, the treatment burden is an issue, as you know, in clinical practice, where patients are not getting enough treatment upfront, and during their treatment course, and their visual acuity outcomes are not as good as what we see in the trial. So, tell us a little bit about PDS with ranibizumab. You've been involved with the program a lot. So tell us how it works, what do we have to do, and what kind of data we have seen so far, and also a little bit light on the recall that was volunteer recall by the company, and then future directions.
Well, PDS was a huge step forward for extended duration therapy. for patients. It is a specialized formulation of ranibizumab, surgically implanted in the eye. Of course, it did demonstrate that 6-month fixed refill exchanges of that ranibizumab prevented the need for supplemental treatment in over 95% of patients. So, of course, that's great. But we saw in the phase 2 ladder trial that the median time to refill in those patients was 15 months. So, I had a couple patients in that ladder trial actually that went out 31 months. So, it might last even longer, right? So, this is an amazing platform for patients. The unfortunate part is that there has been some septum dislodgement that has occurred, and of course, it's not on the market anymore. But we're hoping that the new siliconized needle will allow the PDS to come back on board in clinical trials later this year, and hopefully back on the market early next year for the commercial patients.
Tell us, the surgical procedure and the refill exchange procedure. Those are new things for our field. But of course, I've done many just like you have, and the surgical procedure requires some precision and following the steps, but it's not a difficult procedure. And then the refill exchange, of course, have a learning curve. What are your thoughts on those two things?
Anytime we have new procedures, it takes a lot of precision and following steps carefully. And anytime we think that we can rush into things, that's when problems happen. These procedures have also evolved over time. So, when we first started with vitrectomy, there were lots of complications. Has evolved to be, the greatest thing since sliced bread, right? So, I think that similarly, the PDS surgery has gone through many iterations, including cauterization and narrowing of the incision size and making sure that you do anchoring stitches. And these changes in surgical technique have only made the surgical technique better. Similarly, when we do refill exchanges, the first few refill exchanges you do, you're not going to be so comfortable doing it. But the more that you do it, the more muscle memory you have, the more you're able to tackle the more difficult cases where the patient can't look in the right direction and all those different things. So I think practice makes perfect. These are all things that we can learn. We've done many more difficult cases like difficult PVR repairs and things like that that we can do now. So I think that this will just take more time. What do you think?
Yeah, no, I agree. I think there's learning curves to it, but it is an exciting technology, right? Because we have sustained delivery of anti-VEGF, and we have improved on the safety aspects too, right? Looking at the data from Archway to now Pavilion and Pagoda for DR and DME, where the endophthalmitis rate was zero in both of those trials. I think anything surgery, as you said, has a learning curve and there's refinements over time. And just like septum dislodgement needed to be fixed, and we expect it to come back in trials later this year. Margaret, I think one thing I've been impressed with the patient satisfaction. I have multiple patients with bilateral implants because they got one in the study. We're so happy they were getting every month or every other month injection in the fellow eye. And as soon as it was completely available, they wanted it. So I have multiple patients with bilateral implants, and they only need refills. As you said, you can go longer than 6 months in most people. And it's been really good to see the stability of vision that we saw in the 5-year portal data presented recently. And it's just been a good testament that the sustained delivery instead of peak and trough and stabilizing the CST leads to stable long-term outcomes. What is your experience with the patients?
Patients love the PDS. They absolutely adore it. They vastly prefer it over the injections. I talked to every single patient when the septum dislodgement issue came around, and I said, we could not refill it and we could just go back to injections if we need to. And every single patient I talked to said, no, I don't want to go through injections again. I want to just use the PDS. And even patients who've had issues, small complications with the conjunctiva and things like that, they still love the PDS. Patients who haven't been able to use the PDS for whatever reason, they can't wait to get another PDS back in. So I think that patients are very loyal to that particular technology.
Yeah, exactly. And I think it's very exciting. I actually had a patient where I had to remove a PDS back in the day, and then they wanted it again. And so I put it after it was commercially approved. So I think your point is very valid. So let's talk a little bit about the longer durable injectables. So you have, faricimab that was approved last year, and now we have high dose aflibercept that actually just got approved. How are you utilizing those agents, and what did you learn from the trials, from Tenaya Lucerne studies, as well as from the Pulsar study of high dose aflibercept?
I think we're all super excited to hear that high dose aflibercept got approved, and that hopefully we'll be able to use it in the upcoming few weeks or months. In terms of the faricimab and Tenaya and Lucerne, we know now that these patients are able to go on extended durations with in Tenaya and Lucerne, 45% achieving a 16-week dosing interval. And now keep in mind, these are treatment naive patients. And these were patients that in the real world, maybe we're not using only in treatment naive patients. What about you? Are you using these drugs in treatment naive patients only?
No, I'm using it in both. So, we did the Truckee study where we looked at the data from the patients who were switched to faricimab. So I'm using it in both. Of course, when I first came out, I was using it in switch patients to see if it's potent in terms of drying the retina. And I was surprised to see that after one injection, the majority of the patients that I had for a long time getting monthly injection, mostly aflibercept, were able to dry the retina. And that's what we saw in Truckee. And recently at ASRS, Manny Chang presented the longer term data, 6 injection data, and there's a trend towards improved anatomy, but also visual acuity. And I think for naive patients, faricimab with dual inhibition works really good. I think what I'm impressed with the rapid improvement in anatomy for patients, and especially patients with hemorrhage. And as you said, like if you look at the 2-year data, you have 6 out of 10 patients going 16 weeks, and 8 out of 10 patients going greater than 3 months. So I think obviously in trials you have naive patients and there's some tolerance of fluid. So in real world, I think our goal is to dry the retina. So I think it's an incremental benefit for our patients. And I think that's what we want. And we'll see where high dose aflibercept fits in, right? So it's approved, and we will probably, all of us will use it in high need patients initially to see how it dries compared to 2 milligram or faricimab, right? Is that what you are planning to do also?
Yeah, I think that's how we all use these new drugs initially, is to use them in high needs patients, the patients where we can't get them dry otherwise, and patients who we want to extend out longer than a particular time interval, probably 4, 6. A lot of patients are okay with 8 weeks, but most patients want to go out 10, 12, 14 weeks. So the longer, the better.
Exactly. So I think, 16 weeks is the new paradigm, right? Before it was 8 weeks, and then 12 weeks with brolucizumab, and now 16 weeks with faricimab and 8 milligram aflibercept. But, for me, obviously, the main thing for me is to stabilize CST and visual acuity. And I tell my patients, I cannot tell you how far you're going to go. You hear that your friend is on 16 weeks. I say, my goal is to stabilize your disease so you don't have recurrences, because we know that CST fluctuations will lead to long-term damage. So I think you're right. I think any benefit is good. And some patients can go 16, even 20 or 24 weeks at times, while others are stuck with 4 to 6 weeks. But it's such a variable disease, right? And we have to individualize treatment. So I think data from both Tenaya and Lucerne and Pulsar obviously show us percent of patients with 12 weeks or 16 weeks, which is meaningful to show that these are longer acting agents. But at the same time, I think the real world patient population is so different than trials, right? Trials are so hard to recruit compared to real world patients because of so many inclusion exclusion. So I think the proof is in the pudding. When the drugs come out in the real world, we're able to evaluate. So having high dose of aflibercept as another option for our patients is exciting for the field, for sure. Now, of course, safety is on top of mind, right, Margaret? Like with faricimab and Truckee, we have not seen any safety issues per se. Safety appears to be comparable to other approved agents. What is your experience with safety with faricimab?
I've personally had a couple isolated, mild cases of intraocular inflammation. Of course, no vasculitis or anything like that. They were all treated with topical steroids. And so I think that has been comparable to what was found in the studies. I think that in Chennai and Lucerne, the percentages were around 2% or so. I think that that's going to be pretty much expected. The good thing is that there's been, I think, over 20,000 injections registered by the IRIS registry so far of faricimab, and I don't think there have been significant safety signals so far in the real world.
Yeah, I mean, I think Truckee, we have not seen anything that is unusual. The far Retina AMD study hasn't really, it was more on the efficacy side and showed the efficacy and extension of interval. And, of course, ASRS REST committee monitoring, and now over, 1 million injections done globally. I think we can comfortably say that, the safety is comparable. Of course, sometimes you do get inflammation. I had a couple of patients also with mild, and they resolved. And I actually re-challenged them because nothing else was working, and they haven't had inflammation again. So I think having the safety is important, and I think that's the bar for 8 milligram of aflibercept also, right? The trials have not shown anything different, but it's a little bit more volume. So IOP, of course, needs to be monitored closely, but at the same time, we have to look for inflammation or vasculitis or anything, because I think as a field, we are more and more focused, actually laser focused on safety, rightfully so, because we have good agents that have long-term efficacy and safety, and we don't want to have agents that have safety that is worse than or current agent, or can lead to irreversible blindness like we saw with brolucizumab. That's why nobody uses the drug, even though it was the most potent anti-VEGF out there. So I totally agree with you. I think we will continue to look for that for faricimab in the Truckee study, but also for high dose of aflibercept. Margaret, tell us a little bit about the emerging agents. Tyrosine kinase inhibitor are exciting in that sense that they're pan-VEGF blockers, VEGF-C, VEGF-T, and they're intracellular acting, molecules. And there are multiple programs that are ongoing looking at it, OTX-TKI, EYP-1901, and CLSAx. What are your thoughts on tyrosine kinase inhibitor as a class? For me, they're more of the maintenance therapy, not acute treatments for our patients. But what do you think?
Yeah, there's so many platforms and programs out there for these tyrosine kinase inhibitors. I think that they're the next generation of extended duration therapy. OTX-TKI, of course, is a hydrogel of axitinib, and that is a particular molecule that seems to be really have a huge affinity for VEGF, I think more so than PDGF. But of course, as you said, it is pan VEGF blockade, but it also does PDGF, which is great. And I think they're gearing up for a larger trial later this year because they had really great results at angiogenesis. And there was like a 90% reduction in treatment burden at 12 months in their phase 1 trial. So that's really great for our patients if we're able to, treat them at first with, VEGF inhibitors and then follow it up with long-term hydrogel. EYP-1901 is a bioerodible insert. So that one's a little bit bigger, right? So that's coated by a polyvinyl alcohol. So that one could possibly last in the eye a little bit more. That was tested with the Davio trial. So What do you think about these multiple implants that you have to, inject into the eye?
Yeah, I mean, I think that's a good point. Obviously, less implants the better, and less injections the better. So this is one injection with multiple, right? Two or three implants. So I think it's acceptable if you see great efficacy and there's nothing else. But I think less implants the better, in my opinion. So I agree with you. I think if you have a bioabsorbable implant that completely goes away versus multiple other implants that may go away or may not be noticed but are there, so sometimes patients may have complaints. So I think right now it's all about trying to establish efficacy, but I hope that we less implants the better.
Yeah, otherwise, depending on how well they seem, they might be telling you about their floaters later on, right? And then CLSAx is the suprachoroidal microinjector. That suspension of exit can inject into the suprachoroidal space. What is your feeling about suprachoroidal injections?
I was involved with, multiple suprachoroidal trials, and, I've injected suprachoroidal steroids, I've injected suprachoroidal gene therapy. So for me, it's not a big deal. I think, again, just like anything new, there's a learning curve, right amount of pressure. What is the feel you get, when the space opens up? And so I think it's just a little learning curve, but it's an exciting space because, you can do ocular drug delivery in a compartmentalized fashion without exposing, the iris and the ciliary body and other structures to the drug. So whether you're using a steroid and you don't have cataract as bad as you have with intravitreal steroid, whether you're doing gene therapy and you have less inflammation than you do with the intravitreal injection. So I think it's an exciting space. I think, you know, we again need to generate data on all these programs and look at the risk and benefits and durability and to see where these fit in, right? So if you have injectables that can go up to 4 months, TKIs have to go minimum 6 months, in my opinion. What are your thoughts?
We are setting the bar higher and higher. I mean, we have great agents that have good efficacy. We want great efficacy. We want excellent safety. I think we basically want the best, right? So we're not going to just settle, especially since there's only so much that we're going to stock in our armamentarium. It's going to be too confusing. It's nice to have options, but we want the ones that work the best.
Oh, I agree. And then work and that are the safest and the best, right? So I think it's good to have multiple shots on goal here with multiple program, and we will figure out, which ones are the best. Just you're right. I mean, we have two biosimilars. We had, off-label bevacizumab, ranibizumab approved, aflibercept approved, brolucizumab approved, faricimab approved, and now high dose aflibercept and two biosimilars. And then it's like there's only so much fridge space that we have. So you're right. I think we need to make decisions on what are the best options for our patients in efficacy, safety. What are the payers gonna cover? And so yeah, it's becoming crowded for sure. And I think, as long as we stay true to data and science, I think that's gonna be the way to go. So, Margaret, any other things you want to cover? I know subretinal gene therapy, suprachoroidal gene therapy is also some of the emerging treatments for neovascular AMD with RGX-314. We have pivotals going on. We also have intravitreal gene therapy with ADVM-022 and 4D-150. So, overall, quick thoughts on gene therapy?
I think gene therapy is amazing. I think that all of those are potential game changers as well. I think future iterations of drug therapy available through the port delivery platform, not just ranibizumab in the future, that could also be a potential game changer. So I think there's a lot of extended therapy treatments that are coming available. This is a really exciting time. I'm really amazed how far we've come just in the course of my career. When I started to decide to go into retina, again, it was the time of submacular surgery and photodynamic therapy. So, what a way to go.
It's completely changed, right? So if anti-VEGF and all these other treatment wouldn't be available, I don't think most of us would be retina specialists. It was a very depressing field with patients just losing vision. And so I think we have more to achieve, with geographic atrophy and other diseases. Before we sign off, two more questions. What is your career achievement that you're most proud of?
I really feel like I've been very lucky to have the career that I've had. There really isn't just one achievement that I'm proud of. I've had an amazing journey from the fantastic mentors I had in residency and fellowship to leaping to private practice at a time when there were really very few women in that space. But, I'd say that the single best decision of my career was to join my partners at Retinal Consultants here in Sacramento.
Yeah, you have a fabulous group and you provide care to a very large region. And I have patients who have seen, you or your colleagues, and they come and move to Reno here, and they're always saying good things. You have an amazing job advancing not just treating patients, but advancing treatment options because your group is a big clinical research center too. So thanks for everything you have done for our patients and our field. So I know you're too young, but how do you want to be remembered once you retire?
Well, one of the things I treasure most is that, we develop these close, trusted, long term relationships with our patients. And I hope they'll miss my relationship with them when I retire. And, as well as my painless injections. And I hope my partners miss me for my ability to handle anything, anytime, and remember me as someone passionate about my patients, my research, and, always doing my very best.
Thank you. I mean, you're a role model for many of us. You've done an amazing job with your career, advancing science as well as taking good care of the patients. And yes, your injections don't hurt because I have some patients who come and get mine and they say, "Okay, if you're as good as Dr. Chang, then I will continue coming." So I always shoot for that. So Margaret, it was a pleasure talking to you. Thanks for being here and thanks for the excellent discussion today.
Always a pleasure, Arshad. Thanks for having me.
Thank you. And thank you for listening. Please remember to take the post test and evaluation to receive C credit and to tune in for additional episodes within this podcast series. Thanks.